Good evening, all the aspirants present here. Today's session is Station 4 Abdominal, and the faculty that we have here is Dr. Subhadip sir. He is a physician and in internal medicine and critical care. Sir, you may continue. Thank you. And to all the aspirant, it is going to be a very interactive session, so you can also unmute your mics or also drop a text in the chat box. Thank you.
A very big welcome to all my colleagues who have come this far to have cleared the part one and part two. In most of the cases, you have done that. And you are knocking the door of the membership of the Royal College. And trust me, this is the easiest part of the entire journey, if you can really believe, because there's a lot of misbelief around all this. PACES and the practical examination. But to be very honest, this happens to be the easiest part of the story. If you just follow simple rules, if you're just doing what you regularly do in your words, with a little change in the type of practice, in what you say, what you do, and how you do. So we'll do exactly that in next half an hour or a little more. I'm sure all of you by now have gone through numerous videos where you'll be able to find out how exactly you do an abdominal examination, where in the carousel the abdominal examination lies, and how exactly you are supposed to participate in the examination. So, as you know, in the carousel, it will be a 10 minutes station in the abdomen. And like all other clinical stations, you'll be given a case scenario, which is going to be very brief. You have to go in, examine the patient, finish it off methodically, but within time. By within time, what I mean is that your target should be to finish off the examination in 6 to 7 minutes flat. And trust me, with a good amount of practice, it is easily done in less than 6 minutes time. And once you have done that, you have earned yourself ample time, by virtue of which you'll be able to face, you'll be, first of all, you'll be able to compose yourself, you'll be able to have a little bit of breath, you'll be able to catch a breath before you face the examiner, give your diagnosis, or whatsoever the examiner asks you to. And in the remaining time, you'll be able to face questions, because in the PACES stations, you need not only do the clinical examination, you need to show them that you know your business. And thereafter, there's a lot of there's a lot of marking left over, where you come to know about where the examiner basically tests your skills to clinch a diagnosis, the positive signs in favor of diagnosis, draw a management plan. So there is marks dedicated, if not marks, there is grade dedicated to each of these sections, starting from communication with the patient to presenting the case, having a good differential diagnosis, having the positive cues favoring your first or primary diagnosis, and ending up with safety netting of your practice. Next, please. So, next. So, we'll talk about just the list which give you the common encounters in an abdominal station. So, this doesn't necessarily mean that these are the cases which you are supposed to get, but these are the commonest cases. And once you have gone through the list, if you can click and bring the whole slide into vision. So if you can go through the list, or even if you want, you can, there are more actually. Even if you can take a screenshot, if that is permitted, you will see that this list is pretty exhaustive. There's a lot of cases into this list. And apart from this, there are hardly any cases that are possibly given in the MRCP PACES. Does that mean that there are no other cases they want you to know? Certainly not, but they will never give you a very acute case. Like a case of abdominal sepsis, peritonitis, patient in shock, they cannot give you. Sorry. Acute pancreatitis in excruciating pain, passing on to ARDS with a flow of say 8 liters per minute in oxygen face mask, they're not going to give you. They can give you an abdominal aortic aneurysm, which has been already operated or which is sitting tight inside the abdomen for many, many years, and there's no chance that it is going to be operated. But they will never give you an acute dissection. They will never give you, as I said, they will never give you an acute flare of inflammatory bowel disease. And although you are supposed to get uh, I mean, real time cases, real life cases, but there will be situations where they'll be used as they'll use a semi simulated case. I'll tell you how. Maybe there's a patient with signs of chronic liver failure, which has now been decompensated. Patient has developed ascites, patient has developed jaundice, and the patient has also developed bleeding diathesis. And they give a short history to mislead you into a thought that this might be a drug overdose or drug induced liver injury. So, what do they want out of you in that case? They want you to think in line with the brief summary they have provided with. At the same time, they'll want that they will identify the stigmata of the chronic liver disease if it is present, so that you can say that I think the patient is having a uh, acute flare up of a chronic liver disease. Nothing like acute liver failure. An acute fulminant hepatic failure is never going to come up for a PACES. So this is basically the cases which commonly occur in the faces in the abdominal station, but there are several other cases that you might encounter. Like we had a case of, even in the last cases, we had a case of drug induced esophagitis with halitosis. A very vague case, but there was a lot of clinical findings into that case, and there was a lot of scope for discussion. So, if the case is heavy, the questions would be less. If the case is very light, uh, looking simple, rest assured you're going to get a hell lot of questions and crossings. Next slide. Now, this is how you start the examination. You have to go in. Uh, for all those who are listening, how many of you enter the PACES station and greet your examiner? Anybody who is used to do it? Okay, I think that everybody is wise enough not to greet the examiner, because you are not supposed to greet the examiner formally and actually luxuriously spend 30 seconds of your precious 10 minutes. You can just give a simple nod and then proceed for the examination, unless the examiner asks you to do something else. Because I have seen people coming into us telling that, good morning, sir, or good morning, sirs, unless we tell them, so here's your patient, why don't you proceed? By that time, they have lost one precious minute. So you need to introduce yourself to the patient. And you remember that if you get a patient who doesn't speak English, if you get a patient who speaks vernacular, if there's a interpreter involved, you still need to introduce yourself to the patient, facing the patient. Give every question to the patient. And while the interpreter is giving answers to your queries, it's absolutely decent to glance towards the interpreter, but primarily look at your patient, because that shows empathy, that shows that you are connected to the patient beyond the language barrier. So once you have uh, given your introduction, then you proceed for the consent. But before I talk about the consent, somebody please from the audience introduce yourself to a patient in the abdominal station. Say he's Mr. David. and you are going in and introducing yourself, how would you say that? Well, I think unfortunately have a very shy group. I have seen people going in, future members and fellows going in and saying that I'm Dr. So and so, and I am a student appearing for the MRCP examination today, or I am an examinee appearing for the MRCP PACES examination today. So that is not a fair way to do it. It's a full fledged encounter. It's better to say that I am the house officer or I'm the doctor here in the clinic today, and I wish to examine your tummy or examine your abdominal system if I have your permission. But before the consent and in between introducing yourself, is there anything else that hints your mind that is not there on the slide? Now, if everybody keeps mum, then
The
I'll.
hand
Sanitize
sanitization.
your hands.
That's there in the bottom of the slide. You can see wash hands.
Or check the name of the patient.
Absolutely. You reveal uh, the name of the patient so that you can address the patient in a dignified manner, taking his name or a surname, and at the same time, you're sure that you are dealing with the right patient. Because when you work in the NHS or you work in any standard facility in anywhere in the world, you have to divulge the identity of the patient. You have to reveal the identity of the patient. And that is so very important so that you see the lab reports are actually right. The skygrams are actually right. The CT has the right name on it. So after you have introduced yourself, like I'm Dr. Pal, the house officer today, are you Mr. Roy and are you aged 72 years? Or you can offer to say that, are you Mr. Roy? Can you give me your date of birth, please? So it depends on how you wish to proceed. I usually do not ask the date of birth because if the patient fumbles, I again lose 10 seconds. So I would just verify the age of the patient from my side if it is there on the summary. If it is not there on the summary, unfortunately, I have to ask the patient. Then also, it's a better idea to ask about the age flatly because he'll give you the date of birth. And first of all, he'll probably have a problem matching the date of birth with the appearance of the patient, and thereafter you'll have to calculate the age of the patient from the date of birth at the back of your mind. That again takes away some of your time. And next, you have to take the consent that I would wish to examine your abdominal system. Like I'll have to look at you, look at your tummy, look at you as a whole, and then I might have a closer look. Then I would touch and feel your tummy, press on it, and I might tap on it and listen to the tummy with my stethoscope. I might also listen to your chest. I might also press upon your feet. So, is that okay? Guys, is
Yes, sir.
this
Yes,
okay?
sir. Yes, sir.
That's not okay because I have spent 45 seconds on this elaborate dialogue. I would only say, I wish to examine your abdominal system. I wish to examine your tummy, look, feel, tap, and also listen with your stethoscope if that is fine with you. That is absolutely what you do. You finish it off in 10-15 seconds flat. Do not say more than what is required because the examiner just wants you to hit the bullets. He just wants you to tap the buzzer so that he knows you are enough professional to do your job. And thereafter, you can position the patient. In most of the cases, the patient would be positioned on a couch. If the patient is lying flat and you wish to uh, start your examination in a uh, semi-incumbent position, you have to help the patient. Or if the patient is lying on a couch and you want the patient flat on the bed, you have to help it while doing so. You have to expose the patient properly, and before that, you certainly have to wash your hands. In each step, you'd have to ask the patient for permission. And before you start the examination, one more very important question you should ask. And what is that?
About pain,
Any
if the
any
patient
pain or
has any
tenderness is
pain.
there?
Yes. Are you in pain? Simple. Do you have any pain? Do you have any pain anywhere? And I'll try to be gentle, but let me know if you have any discomfort. So you ask the patient not to wait till there's a pain that you have inflicted. You simply stop wherever he or she is uncomfortable. If it is a lady patient, you'd be provided with a chaperone. If the chaperone is not there, make it a point that you ask for a chaperone. You'd certainly have a chaperone, or you have one of the lady examiners would act as a chaperone and ask you to continue with the examination in her presence.